we are very glad that you're here and very thankful to you for sticking around for this afternoon's session on benefits. Benefits nerds like me, we always worry that all the cool, once the HR lawyers are gone, everybody else will leave the room. But we got a good topic for you, the healthcare reform, and then after this session is the retirement plans and corrections session. Just a couple of housekeeping items. I believe they gave away, or they have tickets for the drawing at the end of today for the iPad mini. And so if you don't have a ticket, get one. And the way we're going to do this, we're going to try to make it as interactive as possible so that we're going to kind of interrupt each other. As to questions from the audience, it would be really great. I'm happy to answer, and I know they are too, your questions. But especially with some of the topics we're going to cover, your situation may not be exactly like the person next to you. So we do a lot of these healthcare reform presentations, and people have a lot of questions, and that's cool. But I would appreciate it if you would just kind of hang around afterwards and come up and bug us, and so hold your questions, if you don't mind, until the end. Jim Prince is going to start us off. I call him Jimbo. And he's going to do go through a timeline of kind of where we've been and where we are with healthcare reform. Teah Corley with PremierSource is here, and she's going to provide her insights on the consulting side of this crazy mess. It's your turn.
Hit it. Okay. Brandon, we do have the Lady Gaga microphones here. Unfortunately, I got Justin Bieber and Taylor Swift here with me. And I'm like Curly from the Three Stooges, right? So these people in the front know what I'm talking about. So we're going to talk sort of as a foundation background, kind of walk through where we've been. ERISA was passed in 1974. Some of you, not them, but some of you may have been alive then with me. Our clothes were horrendous back then. Believe me, I'm not going back there. But anyhow, back when it was passed, ERISA, it didn't mandate anything other than, don't lie to your employees and don't steal their money. I mean, there was not anything that you said where the government said you have to provide these things. Well, they've been sort of chipping it away on the principle of, I guess, if you give a mouse a cookie, he'll ask for a glass of milk. And so, we had COBRA come in and said you have to do, if you're going to have a health plan, you got to do this. And then we had the HIPAA come in the 90s, and we'll talk some more about some changes in HIPAA. And then now we have the mandates that have come in. So let's get some background here. Beginning in 2010, the Healthcare Reform Act was passed in March. It included a number of new mandates, some of which have been in effect since then, some of which apply only to non-grandfathered plans. And remember, a grandfathered plan is a plan that was in existence on March 23rd, 2010, which has not been materially changed since then. So if your plan meets that criteria, then some of these mandates don't apply. If it's a new plan or if you've changed it, then most of these mandates apply to you. So we have annual limits. We've restricted the amount of annual limits, and in fact, beginning next year they go away. We have a new appeals process, a fairly extensive change in appeals where someone has a claim and you deny it, the claim is denied. There's now additional requirements related to the process for appeals. That applies only to non-grandfathered plans. Significant change was the requiring coverage of dependents up to age 26, adult children up to age 26. I think that's been something that has caused a lot of, anguish among plan sponsors because of the cost and some confusion in terms of who has to be covered under that. But that was a new mandate. There's a wrinkle on that related to grandfathered plans in that if you had a grandfathered plan and the child had coverage from from an employer, from the child's employers, then your plan didn't have to cover them. We now have no lifetime limits on benefits. You can no longer, a lot of plans used to have $1 million per lifetime. So once you hit that $1 million, your benefits were done. Now, plans cannot have that. Insurance policies can't have that.
And I think, Jim, one point on that, with regard to your stop-loss contracts, when they first did these, when the lifetime limits went away, but you still were able to turn that into an annual limit up until 2014, a lot of employers still have the annual limits in place, but your stop-loss contracts, now that in 2014, those annual limits are going away altogether, you'll want to review your stop-loss contracts and just make sure that you're comfortable with the level of risk at which those max out. Some employers are looking at maybe going ahead and increasing the aggregate limits under the stop-loss plan, but just something to be aware of there. And then I think also, Jim, the patient assistance programs, a lot of you, with those going away, you may have patient assistance programs reaching out to you. So as a practical matter, it might be a good idea to reach out to your carrier and get a annual limit accumulator report to see if you have any people getting close to that, so you can be prepared for some of those coming on the plan.
Right.
So
Let me scoot over here because, as usual, Tia's got the remote. And it's a good thing because I don't know how to operate it. So we've got these changes. We've got fully insured plans, health plans, and this is a distinction with grandfathered plans. If you have a grandfathered, fully insured health plan, meaning you just buy an insurance policy, that plan can discriminate between highly compensated and non-highly compensated employees. In other words, you can provide much better benefits for highly compensated employees than you do for non-highlies if you're fully insured and you have a grandfathered plan. Now, if you don't have a grandfathered plan, you can't discriminate, although for the time being, the restriction or the mandate that says you can't discriminate is not in effect. And that's not in effect until the IRS gives us regulations that tell us what a discriminatory plan is. So we're waiting on that, and so for the time being, you can have a discriminatory non-grandfathered plan. And if you have a grandfathered plan, you can discriminate. And if you're discriminating, make sure you at least think about whether changes in your plan may cause you to lose your grandfather status, because then you can no longer discriminate.
Hey, Jimbo,
Yeah.
I know you're going to cover this later, but what about self-funded plans?
Mm-hmm.
Well, we are going to talk about self-funded plans. Self-funded plans, which are plans that are not fully insured, plans that you fund yourself, even though you may have a stop-loss reinsurance provision policy. At any rate, self-insured plans have always been subject to non-discrimination. In other words, you can't, under a self-insured plan, you can't provide better benefits for highly compensated people than you provide for your non-highly compensated people. The difference between the discrimination that relates to fully insured plans and the discrimination requirements for self-funded plans is that under the self-funded plan, if you discriminate, the result is that the benefits that are being provided to the highly comped people become taxable. If you discriminate with a fully insured plan, once we get the regulations that tell us what discrimination means, then if you discriminate, you're subject to an excise tax, and that excise tax is $100 per day per person that is discriminated against. So everybody that doesn't get the best benefits, you have to pay $100 per day for each of those people. So you can't discriminate, okay? So we've got the non-discrimination rules. We've got patient protections that came in 2010, and that related to how you could choose your physician, your primary care physician, OBGYNs, and pediatricians. We have the prohibition in 2010, pre-existing conditions could not be used as a restriction in a plan. In other words, you had to cover all pre-existing conditions for participants, people, dependents who are under 19. Now we're gonna have that next year for everybody, but in 2010 that provision came into effect. And then finally, and this is another significant one that we weren't exactly sure how significant it was going to be when it was passed. Non-grandfathered plans have to provide a number of preventive health services and pay 100% of the cost of that. So there's a whole lot of things, including contraceptives, birth control, a number of immunizations, a number of tests like colonoscopies that have to be paid at 100% if you're non-grandfathered.
And some of you have already seen the increases as a result of that in prior renewals. So as we continue, the Center for Disease Control and the United States Task Force Preventive Services continue to research and add new things to that list. And once they identify something as being added to that list and they give it a grade of A or B, you have a year to implement that. So your plans are going to continue to add new preventive services as we go forward.
Right. So and therefore become probably more expensive because you got to pay 100% of the cost of those. So that's our 2010 highlights. 2011, we got the medical loss ratios. You may have gotten that if you have a fully insured or you have an insurance policy. The insurance companies have to pay out a certain amount of the premiums that you pay in for benefits, and if they don't, then they have to rebate some of that to you. And some of you may have gotten checks from your insurance carriers.
For large employers over 200, it's 85% that has to be paid out. But again, initially everyone thought that would be a rebate back to them. So if my loss ratio was 70%, I should expect a rebate. It's actually based on the carrier's book of business. So you may have had a low loss ratio and the carrier on the whole hit their medical loss ratios, so you may or may not get a rebate, but that's something to track with your insurance carrier.
The other 2011 is the restrictions on over-the-counter drugs under your cafeteria plans. You couldn't pay for over-the-counter drugs unless you had unless they were bought pursuant to a prescription, and there were some exceptions to that. 2012, we had the PCORI fees begin,
Right.
and that's a fee. It's $1, I think, per person. That's a fee that your plans have to pay.
Right.
That's going into this. It's patient-centered outcome. There's a research institute that's getting funded,
Right.
and they're supposed to be doing research on reducing healthcare costs. So they're going to charge you all to charge you $1 this year. Next year,
Right.
it's $2 per person.
Yeah. And we've had a lot of questions about the administration of that fee, Jim, and those are coming due July of this year for 2012. And you basically have to take your average employee or members on the plan. It's not just employees. And so there are 3 different methods you can look at. You can use what you reported on your 5,500 as your average for 2012. You can use an actual count, which would take every day and divide that by 365 days. Or you can take an average of a quarterly. And that's an excise fee, so if you're fully insured, it's happening at the carrier level. They're going to administer that for you. If you're self-funded, that's going to be an excise tax that you file on your IRS Form 720.
Right.
So that'll be coming up in July.
Right, and the payment is due in July
Right.
for 2012. Also coming out in 2012 was the summary of benefits that and I'm sure everybody probably by now has gone through that. That's a description of all the benefits. One key piece of that is sort of hidden is that now that we have regulations, we have guidance on how to satisfy this summary of benefits requirements, the requirement that you provide 60 days advance notice of material changes in your health plan now is in effect. Previously, you could change your health plan or change any plan and retroactively tell employees about it. Now, because now that we have the summary benefits, if you're changing something that's in the summary of benefits, you got to give 60 days advance notice. So if you're thinking about making any changes, keep that in mind. And then finally, in 2012, we had the W-2 reporting. That's coming up next January. You've already gone through it probably now, by now, hopefully. You've gotten your W-2s out, so you know that box, and I don't know how many of you have gotten questions from your employees about what is this information about health, benefit plans. So, and that's going to be there, and it looks like it's there for life now. Finally, 2013, we've got, or not finally, but in 2013, we were supposed to issue the notices of the availability of the healthcare exchanges, and it was supposed to go out March 1st, March 15th, something like that. Well, they delayed that until at least September because they don't know what the exchanges are. So we can't notify employees of all the information that they need for the exchanges because we don't know what those are.
And they've met some resistance in Oklahoma.
Yes. We apparently will not have an exchange in Oklahoma. And then in 2013, the cap on flexible spending accounts, the $2,500 per participant cap on flexible spending went into effect. Finally, the coming up, and probably what's most important today, is the 2014, and I'm just going to quickly run through this list and mention them because we're going to talk in more detail about what's more important. But we got the annual fee that we talked about. We've got there are annual limits are prohibited. We can no longer have an annual limit. Remember, we couldn't have we did away with our lifetime limits in 2010. Now we've completely done away with our annual limits. Automatic enrollment was supposed to be in effect in 2014. We're still waiting on regulations or anything related to automatic enrollment. That's for employers who have more than 200 employees. You have to automatically enroll people in a health plan. And no one has figured out what that means. Like, what do you enroll their whole family? Do you enroll just the individual? So until we have regulations, and we won't have them at least until the fall of this year, even if that, the automatic enrollment is on hold. We have cost-sharing limitations that apply primarily in the individual market, small employers. Can't have waiting periods in excess of 90 days beginning in 2014. Hopefully, or purportedly, we'll have some exchanges. No telling what they will be like. Now, we can no longer have a restriction on pre-existing conditions for anybody, regardless of age. We have our reinsurance payments coming up. We have reporting of health insurance coverage. That's your employees are going to have to report whether they have health insurance on their tax returns, and that's where they will, if they don't have it, that's where they will be assessed. The individual mandate, I believe it's $94 for the first year, and that depending on their income may not apply to them at all. So, but that's something that will be coming up. And then finally, probably most extensively, we've got the shared responsibility, which is the tax system that you may pay if you either don't have a plan or it's not good enough. So with that, I'm going to pitch it back over here to Justin Beaver.
Yeah, right.
Oh, I didn't mention the Cadillac tax. Hopefully that if anybody has a question about that, come ask us. I don't think it doesn't apply till 2018, and it's going to be pretty rare.
Okay, you guys. So we're going to talk about the so-called player pay mandate, or also known as the employer shared responsibility provisions that kick in for months beginning after January 1 of 14. I suspect, I know, actually standing up here, I was thinking I can see a lot of folks that we've talked to individually about what we're going to talk about today. And I know that from talking to others that you've been to like 1 million seminars now talking about healthcare reform, and this is kind of the hot topic. And it's because it's really important. There have been some good changes that have come out in the last few months that are helpful actually to employers, I think. We'll talk about those. But, before we were really concerned, very broadly speaking, we were concerned about missing one employee. So if Kathy Haney, for example, picking on Kathy, my friend Kathy, she's sitting on the front row here, if we offered coverage to this entire room of people as an employer, right, under the regs that existed last fall, but we missed one. Well, everybody in here, including Kathy, not just including Kathy, would have been included in the calculation of a tax that we'll talk about in a second. They've changed that, and we're going to get into it. So, January of 13, they changed the scenario. So, what I just told you, if you miss one person, you fail to offer one person coverage, it's not necessarily going to trigger some sort of catastrophic taxes or penalties. But there are a lot of things we talk about today that you can kind of ignore. It's after lunch. A lot of us ate too much for lunch. We're about to talk about something where you really do need to listen up because you're kind of running out of time to look at your employee population and determine who you have to offer coverage to and who you do not. So what employers are subject to the player pay tax? And there are two taxes actually that we talk about here. One is this no coverage tax, which everybody or a lot of people refer to as the sledgehammer tax because it's the bigger one. And then there's a separate tax. They're mutually exclusive. You can't be hit with both of them. An inadequate coverage tax called the tack hammer that applies if you offer coverage, but it's not very good. Well, the only employers subject to these two penalties are employers that have 50 or more employees. And it's not just 50 or more full-time employees. You could have a combination of full-time employees and a bunch of part-time employees that go into the calculation to determine if you have 50 or more employees. We're not going to spend a lot of time on this because I suspect most of the folks here already have 50 or more. A couple things to think about, though. Let's say that you're an employer and you have 30 employees in one entity and 30 in another. If there's common control under the control group rules, then you're going to be considered as having 50. In other words, you can't split up your groups and say, well, we've solved it. We've only got 30 here and we've got 20 on this or 19 on this side. They aggregate your entities when determining if you have 50 or more. The no coverage tax, this is the big one. And this is the scenario that I just gave where before, up until January, if we offered everybody in this room coverage except Kathy Haney, and Kathy was a full-time employee, then theoretically you could be subject to a $2,000 times everybody in this room tax. Now, they've tweaked that a little bit. Generally speaking, as long as you offer coverage to 95% of your full-time employees, you will not be hit with this tax. So if you miss some, you've got a little bit of a margin of error now. But you want to be careful. The other thing we thought about and we talked about a lot in the fall, and we're still talking about it, are independent contractors. I sat in on this morning and heard the very good HR lawyers talk about independent contractor issues that are still there. Well, back to my scenario, if we had classified Kathy as an independent contractor, but she was really an employee before, we worried, well, goodness, if they audit us and they determine that Kathy's really an employee, she's not an independent contractor, and we failed to offer her coverage because we had her misclassified, theoretically, again, you could have subjected the whole room to a $2,000 per person tax, generally. But now that's changed, so we have a little margin of error. The other thing that's kind of cool, if there's anything cool in benefits, let's assume for a second that these 5 tables or 5 sections represent one entity in an employer's control group. And let's assume that section over there that maybe has 50 people in it. So let's say we had 500 people on this side and 50 on that side. Okay, and this group here, let's say you are a bank. And that group over there, that one section, let's say that group is represents another entity in the control group, but maybe I'm making it up, maybe it's a shoe company. And so they've given us these kind of cool rules that say and where this comes up is a lot of you folks that are very good and very proactive HR directors, you know what's going on in your world, but maybe your owner has some other weird business that you don't know about, or he has business interest or she has business interest that you don't know about. And so you worried, well, my goodness, what if the shoe company, I'm offering coverage to my bank, and it's good coverage, but what if my shoe company that I have no control over, what if they're not offering their employees coverage? Then what happens? So we have this kind of doomsday fear. Well, now The good news is when you're looking at who's responsible and who pays penalties, if the shoe company fails to offer their full-time employees coverage, and again, we're talking about a situation where the two entities are owned by the same group of folks, it's not going to subject your population to this tax. It would only be, theoretically, a $2,000 times the shoe company employees' population when they come up with the tax. The other thing that you need to think about, and your consultants need to be helping you with all of this, really. I mean, especially people that were here this morning, I know that you guys have a lot of responsibility, and you don't have the luxury like we do of just sitting around and being nerds and staring at healthcare reform stuff all the time. So you have a lot of different things going on. Your consultants really need to be proactive in helping you with, and you need to be sitting down and talking to them about this stuff. So if they haven't done that, I would encourage you to go back and call them and ask for their help. But the other kind of wrinkle here is in connection with this idea that you only have to offer coverage to 95% of your full-time employees to get the coverage. That's 95% of the bank employees and 95% of my shoe company employees. As long as I offer it to 95% of my bank employees, I don't care what the shoe company does, I'm good. My bank is not going to be subject to a $2,000 per full-time employee tax. The second tax that we've talked a lot about is this, the inadequate coverage. Jim, I love the way Jim described it in our seminar last year. He said, this is where you have a plan, but it's just really crummy. So if you offer your employees coverage, but maybe that coverage is either not affordable or it doesn't provide minimum value, then you're subject to a smaller tax. It's $3,000 on an annual basis, this tax is. And here's the scenario. So, picking on Kathy again, let's say we offer coverage to everybody here, but the plan is just not very good. But let's say Kathy is the only one that goes to the exchange and enrolls in coverage for which she receives a subsidy. This tax is only $3,000 times 1. It's not like the other tax that's $2,000 times the entire room of people. It's a per employee calculation. That's why it's called the tack hammer. It's a little bit smaller. Again, try to make this easy. The first tax, where I talk about this 95% concept. If you offer coverage to 95% of your employee population, you're not going to get hit with a big tax. But the 5% that you don't offer coverage to, if they qualify for a subsidy and go to the exchange, you could get hit with a smaller tax. Three things have to happen for you to get hit with this inadequate coverage tax. Really, actually two. The first is you either offer coverage that is not affordable or it does not provide minimum value. I'll explain those concepts in a second. And the employee goes to the exchange and enrolls in subsidized coverage. I gave this exact same presentation last week, and lady raised her hand. By the way, smaller crowds, I tell people they're not allowed to ask hard questions, so this was an easy one. But the question she asked is, okay, I've been to these seminars, and they say if you offer coverage and someone goes to the exchange and gets subsidized coverage, I could still be hit with the tax. That's not true. As long as the coverage you offer is affordable and provides minimum value, even if they go to the exchange and get coverage, you're not going to be hit with this tax. Minimum value, the concept is this. It's that your plan has to pay 60% of the total cost. Now, Teah, let me ask you this. I was in a meeting with my friend Teah recently, and Teah was talking about this concept and said most plans provide, on the actuarial, and there's a way to calculate it, involves really even nerdier stuff, actuarial stuff. But said most plans run at like 80%, is that right?
Right. Between that, I mean, most of them are going to be over that amount. And HHS has released a calculator, so it's online if you wanted to access that, or we could send it to you just to plug in the numbers. It's a very easy plug and play. But most of the plans that we see, group employer plans, are hitting that number for sure.
So if you have concerns about whether your plan provides minimum value or is affordable, again, I would get with your consultants and let them help you figure that out, because that's not something you want to spend your time working on. There are some ways to determine that, and one of them involves an actuarial calculator. Mm-hmm. The affordability piece, the coverage has to be affordable. So if you offer coverage and it provides minimum value but it's not affordable, and they go to the exchange and get subsidized coverage, you could get hit with this tax. So it's important to know this kind of affordability concept? And generally, the answer is, and there are a couple ways to go at it, but we're kind of streamline it for today. It's the cost of self-only coverage cannot exceed 9.5% of household income. Well, then you say, well, goodness, I don't know what household income is. That's like, if it's a family, let's say it's a husband, wife, kids, I mean, how do we determine household income? I know what I pay Kathy, but I don't know what the rest of the family makes. Well, they've given us a couple of ways to figure that out, and one way, the one that's most talked about, and the only one I'm going to spend any time on today, basically allows you to look at whether your coverage, the cost for self-only coverage for the employee, exceeds 9.5% of their Box 1 wages on their W-2, just for you. Which is kind of I think it's interesting because, again, that coverage could be very affordable on a self-only basis, but the family coverage could be unaffordable, and that would be okay. You would still avoid this tax. Jimbo, do you agree?
Yes.
That's the right
Absolutely.
answer.
Good answer.
And they've got to go to the exchange and prove that all up.
Yeah.
The way that it gets done is it gets proved up at the exchange.
So here's the question: how do we what employees do I need to worry about? And this is the point where everybody just wake up just for 1 second, and this is the point where I would kind of, if you take one thing away, I would write this down or maybe put a star by it. If you have a lot of part-time employees or if you have seasonal employees, you think, well, this tax applies. I have to offer coverage to those who work 30 or more hours on average per week. Well, geez, I know that who my full-timers are, but I don't really know how many hours my part-timers work. And the interesting thing about this, the way this stuff all works, is that, January 1 of 14, these taxes kick in. Well, what if Kathy works 30 or more hours on average in January of 2014, but then she drops and she works on average 25 in February, and then she goes back up in March? You could have this weird scenario where someone becomes eligible, ineligible on a monthly basis. So the regulators have given us a really way too complicated, crazy scheme for figuring out who you have to offer coverage to. And it's a safe harbor, which means, in my world, if someone talks in terms of a safe harbor, it means you don't have to use it, but if you do use it, they're not going to give you a hard time about it. And the way it works is, and I'm going to kind of... The way it works is you take a period of time and you measure your part-time employees' hours and you determine if they work on average 30 or more hours per week or 130 hours or more per month. And you look at their hours over this, let's say, a 12-month period. Like in my example here, we got a measurement period from October 15 of 14 to October 14 of 2015, a 12-month period. So I would look at Kathy's hours. Kathy, I know her hours, she's a variable hour, meaning all that means is we're not sure if she's full-time and her hours kind of go up and down. But I'm going to look at her hours during that 12-month period, and I'm going to keep track of them, and I'm going to calculate, and I'm going to divide, I'll take the total hours and divide them by the number of weeks in that 12-month period, and if it comes out to where she averages 30 or more hours, then I will offer her coverage at the beginning of the stability period. And these, again, I didn't write this crazy stuff, but these terms, it's the concept of you measure a part-time employee's hours during a certain period or a seasonal employee's hours during a certain period, and then based on what happens during that measurement period, you lock them in for a subsequent stability period. So in my example here, Bill Plummer was hired in 2010, and he averaged 33 hours per week during my measurement period. Bill would have to be treated, because he averaged more than 30 or more hours on average per week during the measurement period, we would have to offer him coverage for all of the following stability period, the 12-month period. And it doesn't have to be 12 months, but that's generally what people are going to do, I think. Regardless of whether his hours go up or down. So if the next year Bill's hours during the stability period go down and he doesn't average 30 hours during that period, doesn't matter. You still got to offer him coverage. And also, if, on the other hand, he had not worked on average 30 or more hours during the measurement period, then we would not offer him coverage during the subsequent stability period. And they give us the ability to use a administrative period, basically a period between the measurement period and your stability period to get them enrolled, get their enrollment materials, and get them signed up on the plan if you need to.
And Brandon, I think
Yep.
one other point there, because it's commonly overlooked, is the FMLA leave and military leave. I think is those are treated differently than normal PTO, and we have to shrink the measurement period. So there can be some complexities when they're on leave that we want to just be aware of.
Yeah, and Tia's trying to get me to talk about something really hard, which I'm not going to do. But
Just to be aware.
But when you look at this, when you measure someone's hours during these periods, you have to factor in hours for which they get paid for things like vacation and sick leave. FMLA can create some kind of weird nuances, right? So if you've got those, again, your consultant or your lawyer should be helping you with those. They've given us another nerdy, and this is talking about running out of time. You're running out of time to do this particular slide. You're running out of time to take advantage of a new little special rule they gave us just this one time. So generally speaking, they don't want you measuring someone's hours, like they wouldn't want me to measure Kathy's hours for 3 months and say, well, she didn't average 30 hours during that 3-month period, so I'm going to lock her in for 12 and I'm not offering her coverage for 12 months. Generally, your measuring period has to correspond with or be similar to your stability period. Solely for 2014, they allow us to use a 6-month measurement period. So you still have time. As you sit here right now, this is April the 23rd or whatever, you could theoretically you could use this, take advantage of this one-time special rule and measure the employees who work for you today, measure the part-timers, measure their hours as late as starting July 1. Now, I would not wait till July 1. If it was me, I would recommend you start maybe May 1. Look at your part-timers' employees' their hours from May 1 to October 31. Just like we've got in this example, I think. Right here. So you look at their hours during the 6-month period starting May 1. If they average 30 or more hours during that 6-month window, then you're going to lock them in and offer them coverage for all of 14. And likewise, if you look at their hours during that 6-month window and they don't average 30 or more hours, then you're not going to offer them coverage for all of 14. So now is kind of the time to take advantage of this. The other thing that I would say, a lot of the clients that we talk to, here's what they're saying: I don't want to mess with this crazy stuff. And by the way, I've kind of talked to you about the easy. It's hard. It's easy to talk in terms of the folks that work for you now. If we're talking about the people that are let's say this whole audience works for the same employer, it's easy to think how we're going to measure their hours on an ongoing basis. What's hard is, let's say we hire these 15 people at different times over the next 3 months. Well, theoretically, you should be measuring all of their hours in different windows, and so it's more nuanced and more complicated with respect to new hires and seasonal employees. But here's what a lot of clients are saying: I'm not going to mess with this. This is crazy. I don't have time to sit around and measure hours and track different periods. So I'm just going to push my part-time. I'm going to say, you know what, if you're part-time, you're not working more than 29 hours, ever. And that's cool. I mean, there's a little bit of risk, but a lot of people are doing it. That's cool. That's fine. But if you're going to do that, even if you're going to do it that way, I would still encourage you to use this measurement period. And when I say using a measurement period, all that would mean, to the extent it's possible at this point, for you to restructure hours. You go to your part-timers and say, I'm sorry, we're going to have to make sure that your hours are where we've really always wanted them to be, and that is under 30 hours per week. And that's effective May 1, or that's effective June 1. And then that way, for those folks that you're pushing down below the 30 hours, the part-timers, so that you can avoid this craziness, you can say, if you're ever audited or someone ever comes back and questions, you can say, we measured them during that 6-month window and they did not meet 30 hours during the period. I'm going to kind of move through so that we have time for Jimbo and Teah to talk about some of the other stuff. But waiting period restrictions starting January 1 of 14, your waiting period cannot exceed 90 days. They've given us some cool wrinkles as to how this waiting period restriction ties into this measuring concept. Don't have a lot of time to cover that today, but I'd be happy to visit with you about it if you want to talk about that on the break. So everybody's talked about the PCORI fee. This is $1 per belly button, isn't it? Yeah.
Yep.
It's $1 in the first year, $2 for this coming year. But But the reinsurance fee is really a much bigger deal. And for a long time, nobody was talking about it. Everybody kind of ignored the reinsurance fee. But it's, as I understand it, and when you get into the exchange concepts and how all the economics works behind healthcare reform, I kind of snooze over. It's boring enough not talking about the economics. But as I understand it, this fee is one of the fees that's designed to help offset the insurance company's costs when they have uninsured folks that are going to run to the market and get coverage, theoretically, starting next year. It's $63 per belly button, and it's going to be due, we think, in January 15.
Right.
Right?
Yes. And this one can be taken from the plan assets. And so it can be administered, most of the fully insured plans will be administered by the carrier. And then on the self-funded plan side, you can have that administered by your TPA, but it can be out of the plan assets.
And tax deductible.
Yes.
If the employer pays it.
Teah, why don't you, so this annual fee on health insurers, Jim actually sent an email to our group. We do this a lot, like, hey, is anybody, what has everybody read about this? And Jim, maybe a month ago, sent an email and said, hey, who's looked at this new fee on health insurance companies? And I don't really pay much attention to what health insurance companies are getting charged, except this is a fee that we think is going to be passed along to our clients, which is a big deal, and it's a pretty significant deal. So, Teah, why don't you?
It's called the, so in addition to the reinsurance fee, it's an insurance industry fee, if you will. And we had plans that have renewed in April, and so we've been able to see kind of 3 months worth of 2014 built into that. And many of you maybe have heard the reports about, the carriers bracing us all for, expansive increases in 2014. They're looking at bracing us for 30 to 50% increases, if you will, from a fully insured perspective. But what we're seeing is that insurance industry fee is being passed through to the employer, and it's currently looking like it's going to run anywhere from 3 to 6% of the premiums. And again, then the reinsurance fee is on top of that. And what they're saying is that really the increase that they're talking about is more about the uninsureds coming on to the fully insured book of business. So we're not seeing an expected increase. Right now, the trend for 2014 is projected at about 7.4%. So not the 30% increases that you're talking about. We think that those increases are more for the smaller groups where they're subject to the book of business, if you will. And so the carriers are having all these uninsureds come on to their book of business. So the smaller you are, the higher the percent of your renewal is tied to that book of business. So just some updates there on some things to expect at renewal.
And so, Teah, if you're self-funded, then this is not something that you should be glad you're self-funded, right?
Right. The self-insured plans will not be subject to that insurance industry fee. So that's being assessed only to insurance companies, and it doesn't affect stop-loss providers. So that's one fee that the self-insured groups are getting out of. And then we are starting to see more of the markets are coming out with new reinsurance products that are basically self-insuring smaller sized groups. So they're going down lower, and we're starting to see more of the fully insured plans kind of migrating toward self-insurance for 2014.
Teah, we used to think 500 lives was the minimum for a self-insured plan. Is that saying that may come down so that self-insured plans may make more sense for smaller employers even?
Right. So that number's coming down. Right now, kind of from a credibility perspective, they say 20% per 100 lives. So 20% of your own renewal would be tied to your experience if you're 100 lives, and then the rest of it is tied to how that pool ran. But we're starting to see the stop-loss providers are coming out and saying we're gonna lower our margin or our target for the size groups that we're gonna insure. So we're seeing more, anything kind of over 100 really, and some even less than that.
So I'm going to talk just very briefly about wellness and changes to the proposed regs and changes to the new, the wellness rules. So this would apply, these healthcare reform added a few little wrinkles to wellness, and basically if you have a wellness program that requires employees to satisfy a standard, like not smoking, to receive a benefit, or they get hit with a surcharge. That's the most common, or maybe a certain cholesterol level, and then they get a discount, or they these new rules apply to you. In the past, the maximum permissible reward was 20% of the cost to cover. So if you had, for example, a program where someone either signed an affidavit and said, I'm not a smoker, and therefore their costs were less than someone who signed up and said, I am a smoker. In the past, that difference, the delta, could only be 20%. Well, now, starting in 14, it can go up to 30%, and if it involves tobacco cessation, it can be as high as 50%. One of the questions that we got just this last fall, before these new rules came out, was with respect to tobacco cessation programs. Well, if Kathy signs up and says, I'm a smoker, and we say, well, Kathy, you can get the benefit of the discount, of the cheaper rate, as long as you participate in a class, tobacco cessation program. That's fine. Well, the question we got asked a lot before was, can we make Kathy pay for it? And the answer is no. And then you get into weird scenarios. Well, what if she signs up for the program every year, but she's never stopping using tobacco? Well, you got to give her the ability to qualify once a year, and every year she can re-participate back in the program. Jimbo?
Sure. Well, I don't know what to do with this.
Do you need me to do this for you?
It's really because at my house, I don't ever get to touch it. I mean, and that's the truth. I don't ever get to touch it because we got to have the housewives of somewhere on all the time. Yeah, we've almost gone from the cool stuff that Brandon was talking about into the kind of mind-numbing stuff. But let's talk about, we mentioned health reimbursement accounts, and this is a myth that needs to be debunked here. We understood some people were saying, as an alternative to having a health plan, you could set up a health reimbursement account, which is a defined contribution health plan. In other words, the employer says, I'll give you $10,000 and I'll put it into this account for you, and you can spend it on your health care. Whatever way, you can go buy your own insurance, you can just use it, you can use it whatever way you want, and that counts as our health plan. Well, we didn't think that worked initially because there's a limit there. There's $10,000, and we knew that we had these annual and lifetime. We couldn't have annual and lifetime limits, so we couldn't figure out how health reimbursement accounts would fit into that. And in fact, in January, the government clarified that that a health reimbursement account won't satisfy the requirement to have a plan, and so that you can only have it, and you cannot have a plan that has an annual or lifetime limit in it. So any plan that you have either has to be an accepted benefit, such as a cancer policy, a health savings account, or it has to be connected to an integrated, full-blown health plan. So you can have a health reimbursement account, but it can only be one that is associated and is integrated with your health plan that meets all the other requirements, including the requirement that the requirement that there be no lifetime or annual limit on the amount of benefits that can be paid out. So that's the myth that's debunked. You can't substitute a, quote, defined contribution health plan for a health plan that's going to satisfy the requirements of the Affordable Care. The other thing that we mentioned earlier is non-discrimination testing, and this has been largely ignored. Most health plans didn't do any testing to determine whether the benefits that were being provided in a discriminatory manner to highly compensated employees versus non-highly compensated employees. That has been the law for as long as I can remember, at least since the 1960s, that and not that I knew in the 1960s, by the way, but just it does go back to at least the 1960s, that you can't discriminate on a health plan other than you could provide an insurance policy that discriminated. In other words, you could buy an insurance policy for the owner and not have anything for anybody else. And that's if you had that policy prior to March 23rd, 2010, and it hasn't been changed, then you can still do that. You can discriminate, and this is what I was saying before. You can discriminate if you have a grandfathered, fully insured policy. If you don't have a grandfathered plan, or if it's not fully insured, then you're subject to this non-discrimination requirements. 105H basically provides that you got to be fair in terms of who is eligible and the amount of benefits that they get. And some of the things that we see that probably doesn't pass the requirements under 105H, the non-discrimination, and will probably not pass the non-discrimination requirements that are going to come about for fully insured plans, are things like letting the executives or highly paid people become eligible immediately and have everybody else have to wait 90 days, or previously 6 months. Also, you can't provide certain benefits for the highly comped and not to the non-highly comped. And then finally, the percentage of premiums that you pay can't be discriminatory. Excuse me. So that's something, as we said, it's been ignored. Hardly any self-insured plans have been doing non-discrimination testing. We expect that the government, the IRS, will at least say that they're going to start focusing on this, and say you better get ready for us to come audit your plans and see whether you're discriminating. And if you are, the effect is, if you're self-insured, the benefits that are being provided to the highly comp people become taxable.
And Jim, I think one distinction, and maybe you can answer this, but this is a little bit different than what you were talking about earlier, in that now we're looking at controlled groups, or if we've got multiple employer plans, it's on aggregate now, right?
It is aggregated. We have to, like Brandon said, let's say we had 5 different companies in here. We have to aggregate them together for purposes of determining whether we're discriminating. So if we've got a really good plan for company A over here, and we have a bad plan over here, we've got to combine the two to see if we're being discriminatory in terms of the two plans. One exception to that requirement is there are some plans called they're diagnostic plans, and so an employer can pay for diagnostic tests like X-rays and blood tests purely for diagnostic purposes on basically a discriminatory basis. So you can say to your executives, look, if you want to go have a health checkup and have your the blood tests and all that, X-rays, that can be paid for separately and apart from your regular health plan, and that's an exception to the non-discrimination requirement. We've been told, like I said, we expect that the IRS will announce that they are looking at discriminatory practices in health plans. We've also been told that the Department of Labor is going to start looking at plans for compliance.
And we've had some employers actually get those letters, so they have started. And I think we got a little bit of a break under PPACA where they weren't initially, when the audits were first taking place after the implementation of PPACA, they didn't include some of the checks that they're looking for now, including grandfathered status. If you ever were grandfathered, they're going back to that period. So even if you've lost your status, they're asking for your confirmation all the way back to 2010. So if you were grandfathered for 2011 and you lost your status in 2012 or 13, they're still going back and looking that you provided the proper notices at that time, that your file is documented for all of that.
And your file needs to include your plan documents, summary plan descriptions, as we said, any changes, and keep in mind this new 60-day advance notice requirement on changes to your plan, all the notices to employees. So you've got several notices that have to go out when the employee first becomes eligible, and you ought to have a package of notices. Teah, you see that. What do you have? A HIPAA notice. We have the initial COBRA notice.
We also have to have, the grandfather notices, the notice of the age 26 dependent eligibility. So there's a checklist of those, and what we wanted to at least offer, if any of you, we've kind of put together an internal audit or a self-check for preparation for a DOL audit that we're happy to just email out and make available to you, that comes from the DOL website. But normally that letter comes and you've got about 10 days to respond. There are about 49 items that they're going to ask for, 26 of those that you have to provide in advance. So if you want to kind of be prepared for that, we're seeing a big influx out of the Dallas DOL office, starting to kind of migrate this way as well. So we're happy to just, again, send that out to you to prepare.
Yeah.
Can I add one thing too, Jimbo? That so they said this earlier with respect to the HR side, but I think it's really true for benefits, is if you get a letter from the DOL asking for benefit plan documents, whether it's retirement or health plan, and telling you they're going to show up and be at your place of business on such and such day at such and such time, I would strongly recommend that you get your lawyer, if it's us, get us involved at that point. Because there's a lot of things that you can do strategically to deal with them in an appropriate way and to shield. What I never want is, I don't like the DOL person having access to our client without me being kind of in between. And not anything improper, it's just you want to be there. If they have questions, hey, I'm going to be here, I'm going to work here too that week, and I'm going to help you with whatever. And the other thing I like is, if you get that letter, I want to go through it with you, and we're going to find out what you have and where your dead bodies are buried, and we're just going to tell them when they get there, hey, we've went through, and here's all the stuff you asked for, but we got a problem here, we think. And they're very open to that. So I would, again, this is not something you want to try and handle on your own. I mean, you can, but I would get us involved or get your lawyer involved very early in that process.
Yeah, and I might add, you might want to, look at Teah's checklist before that happens, and that way you're even more prepared. The Department of Labor is they're busy. They have a lot of things to do, and the more you can be organized in presenting things to them, the better off you are, because they're going to be less likely to be going far afield from what they specifically are looking at. So, that is on the horizon. Okay, so now we've gone from the mind-numbing stuff to the coma-inducing portion of the. We've got some changes to HIPAA, and just in case you don't know, and slap the person next to you that's falling asleep over there, please. HIPAA, as I mentioned before, was passed in the 90s. I think 96. Yeah, 96. It's health insurance portability and accountability, and it kind of had a couple of parts. One being the portability, which was, if you had coverage, you ought to be able to move to a new employer, not be subject to pre-existing conditions, and not be subject to extensive waiting periods. But it also has provisions for privacy and security, and so. This past January, there were new regulations issued by the government in terms of the security and privacy provisions. And I know this is difficult, but it is important. We've got some. It's important because there's some significant fines that can be assessed if you violate these really kind of technical requirements, and they're requirements that you can satisfy and not be subject to fines. So we've got a few examples. Most recently, this hospice of Northern Idaho. This was a plan. Pardon me, a hospice in northern Idaho, remarkably. that had fewer than 500 patients and they had people that carried laptops that had protected health information, and the laptop got stolen. So protected health information is any information about a person's that is personally identifiable. So somebody that knows that I'm me and they know my personal medical stuff. So that's protected health information, anything that can link the two up. So we've had these others, and so that's why we've included these as a kind of a wake-up that there are these significant penalties that you can get assessed with, and it is an arcane kind of situations area. But what is new is we have a new standard for what is a breach of the HIPAA requirements. The HIPAA requires a number of things, and has required for a number of years, that you protect your health information, that you make sure that it doesn't get disclosed to somebody who doesn't need it, or who is not authorized, that you train people who have access to it, and that if you have a breach, if your information gets away from you, that you have to notify not only the people who are affected by the breach, but in some cases the government, and in some cases you have to notify the press. So there have been changes that came out in January of this year related to the requirements related to protecting your health information. One is a new standard for breaches. And I'm going to quickly go through these and then go into a little bit more detail about what some of them are. The next one is regulation of your business associates. We have new requirements for your policy, your documents, and the notices that you give to people. The regulations have then made it clear that genetic information that is collected is protected health information and is subject to these privacy and security requirements. And then finally, there's some new requirements that allow a participant to request from you their own protected health information in an electronic form. And also, participants now have the option to have their healthcare provider not report and therefore not make a claim to your plan. So if I'm wanting to get a prescription for Rogaine, and I don't know, I guess you don't need a prescription for Rogaine anymore. Brandon was afraid I was going to say Viagra, but if I'm getting a prescription for Rogaine, I can tell my doctor, I don't want this reported. So I'm going to pay for it myself, but I don't want it to be reported to my health plan. Right. That's a new option, and that's something that your participants have to be made aware of. Mm-hmm. So let's go kind of quickly. First of all, the deadlines for this. The regulations became effective in March, but we're not required to comply until September 23rd. So you're going to have to update your notices and your privacy policies, and you're going to have to adopt some additional things and put them into your business associate agreements. But all of that does not have to be done until September 23rd, 2013. And with respect to business associate agreements, you don't have to get those redone to reflect these new requirements until September 22nd, 2014. Business associates are the people who work on your plan for you, okay? So anybody that is associated with your plan that works on it, your actuary, mm-hmm. Your brokers, mm-hmm. they're all business associates. And we are kind of running out of time, but let me tell you the new requirements for business associates are that there's new language that has to be included in them that requires your business associates, if they hire somebody to help them, to have agreements with their subcontractors. In addition, depending upon the language of your business associate agreement, you may be liable for what your business associate does. So if you hire a law firm to work on your health plan, and the law firm, you need a business associate agreement with your law firm, but if they're going to get access to protected health information, and then in addition, if the law firm hires somebody else to help them, the law firm needs to have an agreement with the parties that they and your agreements all have to reflect that. So that all of your business associate agreements are going to probably need to be updated. Your HIPAA policy, and you need to have a HIPAA policy statement, needs to be updated to reflect these new requirements. And then finally, your notices to your employees that you pass out need to be included. I mentioned the GINA. Genetic information is specifically now identified as protected health information, and it is in a separate category because it cannot be used for underwriting purposes. You can't use genetic information. First of all, GINA, the Genetic Information Something Act, says you can't discriminate. You can't discriminate against somebody either in employment or in benefits based on their genetics. Now, you can gather, in some instances, get that information, but then HIPAA says you can't use that information for purposes of underwriting. You can't, so you can have it for healthcare purposes, but you can't use it for underwriting.
And I think long-term care plans are the only ones that can use it for underwriting. But as a practical matter, for those of you who have health risk assessments that you're asking employees to fill out, and maybe you're offering an incentive for them to fill that out, and you maybe have some questions on there that may be of genetic orientation, they're just recommending, or we're recommending, that you have some language on your health risk assessment that says that you can still get the incentive even if you don't answer these questions. And so kind of having a bifurcated health risk assessment to make sure that you're not penalizing someone who answers genetic questions the wrong way.
So let's run into the what's going to be required. Your privacy, the notices that you give to participants about privacy are going to have to be revised. First of all, as I mentioned, they have new rights that they're going to have to opt out, to not have something disclosed, and also they have the right to receive their electronic protected health information. If you haven't, the new notices, the timing of that depends on whether you've got a website where you post notices, and if you have a website, you've got to have the new notice posted by September 13th, and then distribute it with the next annual mailing to participants. If you don't have it, you just revise your written notice and then distribute it by November 22nd of 2013. So it's supposed to sort of dovetail with the typical open enrollment periods, but whether it does for you or not, it depends on your plan. And by the way, then one final thing, distribution by email is permitted. This is one of those things that the notices can be. So let's run through the requirements that we want to take in connection with these revisions to the HIPAA. One is you've got to update your security, your breach notification provisions to reflect the new breach standard. And I didn't go into detail on that, but the new breach standard is previously a breach didn't occur. It was kind of a no harm, no foul rule. So if I'm getting Viagra, or if I'm getting, not Viagra, if I'm getting Rogaine, see, Brandon was afraid I'd do that. If I'm getting Rogaine and that gets disclosed, well, I mean, it's not a secret, right? You can see it. And so that wouldn't necessarily be a breach. But now, if that information gets out, it's deemed to be a breach, and you as the employer have to prove basically that it's not. So there's a new standard in terms of what happens if a breach occurs. You've got to also do a risk assessment analysis if you have electronic protected health information, and everybody does. And then finally, a couple other things. We've got to review your policy requirements, update your business associate agreements, and then revise your notices of your privacy practices. That's as fast as I can go. And the red light I see is on back there, so.
So we were done up until a few days ago, and we were almost done. I'm just going to cover one thing that's not in your materials. I believe it's on the screen. Last Wednesday, the United States Supreme Court issued a new decision involving subrogation. And this really, to put this in practical terms, if Teah was an employer that had a self-funded plan, and Teah provided, and Jim and I were in a car accident. Jim works for Teah, and let's say I rear-end Jim on the way back to the office. Well, Jim, let's say he sues me. This is exactly what happened in this scenario. Jim sued me for $1 million. He gets $100,000. Well, Teah had paid a lot of money for his medical care, and Teah wanted her money back, and she had a right to it under the terms of the plan's subrogation provisions. This case that was issued last week, not going to spend a lot of time because we're out of time. Basically, there are certain provisions, certain language you need in your health plan to properly and adequately enforce your subrogation provisions. So I would get with your consultant or your lawyer about that as well. Thanks so much for your time and attention.